Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good afternoon, everyone. Thank you very much for joining us for our webinar this afternoon on Medicare policy versus the conditions of participation. And Arlene Maxim is going to help us understand both of those and how they're similar and, more importantly, how they're different. So my name is Mike Carr. I'm the Director of Training and Education here at Axxess, and very happy to be joined by Arlene Maxim, who's the Senior Vice President for Clinical Services, who's probably a familiar name and face to you guys. In the GoToWebinar panel along the right, she's got a pseudonym up there for today, so appears as Ray Ann Melton, but it's really Arlene who will be presenting to us today. So first of all, if you could please, if you have any questions along the way, please go ahead and enter those in that question panel on the GoToWebinar pane along the right-hand side, rather than the chat. The question panel will let us capture who's asking them and the email address, and if we don't know the answer during the webinar, we will know who to get back to afterwards. So that would be great. You will earn a 0.5 continuing education nursing credential for attending this session, and that's awarded through the ANCC, the American Nursing Credentialing Center Commission on Accreditation, which is quite a mouthful. So in order to do that, we will again capture your email addresses from your attendants, and then we'll send out communication to you later on this week about how you can access that, and it'll actually be through the Axxess Training and Certification platform, and there'll be step-by-step directions on what you need to do to get that certificate. So you'll need to answer a few questions about the content that's being presented today, and then fill out a quick little survey, and then you'll have your certificate at that point. So if you have any questions with any of that process, please feel to reach out to me at mcar@axxess.com, and I will be happy to help you along that road. But I think that's all I have for housekeeping stuff, Arlene. So Happy New Year, and take it away.
Well, Happy New Year to you, Mike, too, and thank you so much for the kind introduction, and thank you everyone for being here today. This is really one of my favorite things to present to folks in talking about the differences in conditions and Medicare policy, because oftentimes this is one of the most misunderstood things in our industry. And when clinicians are trying to document or they're trying to learn the industry itself, it's confusing oftentimes as to who's requiring what and why they're requiring what they're requiring. And so I'm hoping that by the end of today's session, you're going to be able to identify the difference between those two items, the Medicare policy, which identifies the skill that we are actually paid for through the Medicare program. And we're going to talk about the difference in complying with both Medicare policy and the conditions. And we're going to talk about the three accrediting bodies. But to start out with, we just want to talk a little bit about how these things are different. So in the conditions of participation, you'll find those in Appendix E, or I'm sorry, in Appendix B, in the CMS manual. So if you look under, in the CMS website, you look under manuals, you'll find the Appendix B, and it's part of the state operations manual. And these are the rules and the regulations that were actually enacted by Congress. And this is the foundation for allowing us to bill for the Medicare program. So before we even get into Medicare policy, as far as an agency, we must make sure that we're complying with every single one of the conditions of participation. Most of what we talk about with the conditions of participation, and most of what the surveyor will look at in the conditions of participation, has to do with patient quality of care, and has to do with safety, has to do with all those things that we look at for making sure that we're following physician's orders and we're documenting safe patient care. So Medicare conditions are dealing primarily with quality. Now the conditions, again, are found in also the accrediting body standards. The standards, they each have Joint Commission, CHAP, and ACHC all have their own standards. but the conditions of participation do not change. Those are all the same. So if the organization, or if your organization is accredited, then you have additional items that you need to comply with, but primarily all of those items are dealing with quality. In Medicare policy, on the other hand, Medicare policy is providing guidance for what we can actually bill. So the Medicare policy, and this is the same no matter what accrediting body you're going through. Medicare policy is always the same, that it tells us what we can actually bill for. And I often talk to organizations about how Medicare needs to be looked at as an insurance company. That's primarily what it is. It is an insurance program, and there are certain things they cover and certain things they don't cover. And so, for instance, if you have home insurance and you have a flood and you don't have flood insurance, it's not going to be covered under your policy for your home. It's the same thing with Medicare. If it's not something that's listed in policy, it's not going to be covered and you're not going to be paid. So if the documentation is not there to cover the policy, to cover the covered service, then you will not be paid for the services. You could have pristine documentation in relationship to conditions of participation. Surveyor could come in here into your organization and say, you've met all the conditions, everything is perfect, you've got a great infection control program, great QAPI program, you have great minutes for all your meetings, your personnel files are perfect. But if your policies are not followed and you do not have documentation to support those policies, you're not going to get paid. So it's important for you all to recognize that these are two entirely different issues, so that when we're doing documentation, and in your EMR, and Axxess as an example, in the EMR, we are looking for those items that support not only the conditions, but also policy at the very same time. So you need to think about that as you're training your staff in documentation, going through your orientation. And clinicians really need to understand what that difference is, that the conditions are absolutely related to quality, and Medicare policy is related to payment. So each of the conditions provide guidance that function in the specialty. So we have conditions of participation in hospice. We have conditions for hospitals have their own conditions, nursing homes have their own conditions. But again, these are all related to taking care of patients safely and effectively. They give us guidance to use certain types of that's unique to home health care. So our conditions in the home health care arena are very unique to us. So they're things that are very specific to us as an organization, and then going out into the home. So hospice and home care, of course, are the only two entities that actually provide services outside the actual organization itself. So we're going into the home to provide these services. And it also provides guidelines for it's helping us to have positive patient outcomes. So we always want to look at our OASIS documentation. There's a little bit that enters into that as far as payment is concerned, but most of OASIS is determining the assessment itself, and it's the basis for us determining outcomes. And then again, in value-based purchasing, we want to make sure that we have, that's coming around very quickly, we're going to make sure that we have good outcomes, and those outcomes are defined, and they're also analyzed by surveyors when they come in to look at your clinical records. So nurses, again, they don't need to know all the conditions. So, but they really, as far as your orientation is concerned, I highly recommend that you have a very strong emphasis on the conditions and what they mean, and why the surveyor is so concerned about the quality of care when they actually go out to do home visits, and when they're looking at their documentation inside the agency. So there are things that oftentimes the surveyor will look at, and again, as I mentioned earlier, that will indicate compliance with the conditions, but aren't necessarily compliant with policy. So for example, a personnel file, organizational requirements, emergency planning are not areas nurses bear responsibility for. So them understanding all of that and all the detail behind that, and there's a lot of detail on these conditions, that's not necessarily something that the nurses and the therapists need to really understand, but how they are important to know that they are obligated as clinicians caring for patients, and it's their individual responsibility to make sure that they keep up with the requirements. And as those requirements change, we had the most recent change, of course, in 2018. It was a significant change, as a matter of fact. And those changes, it was necessary to make sure that you've trained your staff. And I still hear from organizations today, I can't tell you how many phone calls I get in a month, and many organizations don't even realize those 2018 conditions changed, and they're still trying to force things in the way they had done them in the past. So it's important that if you're a leader in an organization, you keep up to date with all of those changes. So we're going to cover areas of the conditions that you're going to need to have a good understanding about during this session. And again, as I mentioned, this all has to do with quality. So the conditions are standardized rules and regulations. These are things, the conditions are actually laws. And if you look at the Appendix B, you'll see the condition listed as a 401 number. And along with that, the law is stated there. And then we have an interpretation of that law. That interpretation is not the law. The interpretation is something that someone at CMS looked at and they said, well, this is how we're going to interpret this. But there's always room for negotiating within the interpretive guidelines. So keep that in mind. The state surveyors follow these conditions when they're doing their surveys. My recommendation to every organization is to download a copy of Appendix B, have that with you at all times when you're going through a survey, and make sure you make little notes. I recommend you make notes in red so that you can see them. You all know that when a surveyor walks in, oftentimes it's a very stressful time, and sometimes we forget that we have certain policies. If we have notes next to some of the conditions and some of the standards, that'll help us remember where we can find different things. We can put page numbers for our policies. We can put reminders for ourselves for all kinds of different things on Appendix B, but have that available and with you at all times during the time the surveyor is doing that survey. I mentioned before that CHAP, Joint Commission, ACHC are the three accrediting bodies. Those are the only accrediting bodies we have right now in home health. Those are the only ones that have been approved by CMS to actually review home health. And there are two things that these organizations do. One, they do accreditation, which means that they will look at your organization and determine whether or not you meet their standards as far as an accrediting body is concerned. As I mentioned, they all have standards higher, maybe higher, than the conditions. So, but they're all different. So Joint Commission's accreditation standards are different than CHAP's, and CHAP's are different than ACHC's, and Joint Commission is different than ACHC. So if you're going to decide which organization you're going to go with, you need to look at those accrediting body standards. So the accreditation has to do with their standards. So you can get accreditation all by itself. You don't have to get what's called deemed status. If you have deemed status and you've asked the organization to survey you related to deemed status, that means that these organizations can look at you and look at your organization to determine whether or not you meet all of the conditions and you satisfy every single condition that's necessary to become a Medicare provider and to continue to be a Medicare provider. And I've had some organizations who have lost, they've been certified by one of these three, and they have lost their accreditation status, and they've actually lost their deemed status, and thinking that in losing that because of a bad survey, that they are no longer able to bill. That's not true. The primary decision to remove the provider number lies solely with the state that you're working in and with a regional office. So just because the accrediting body removes deemed status and or accreditation does not mean that the organization has lost their ability to bill to the Medicare program, not until the state comes in or the regional office comes in and says that that's the case. So I just want to clarify that because that's something that many organizations misunderstand. They don't understand that those are two different things that we're working with. So now let's talk about Medicare policy. So this is another part of our job in making sure that our documentation that we submit to the Medicare program is in compliance with Medicare policy. I always tell people that when you bill the Medicare program and you get paid from the Medicare program, you need to think about that as a short-term interest-free loan from the federal government until they look at your record and say, you know what, you've documented everything perfectly and you can keep that money. That doesn't happen. Doesn't happen all that often. Many of you who have gone through ADRs, you've had UPICs, you've had other reviews going on for with the Medicare program, that you know that oftentimes that money is taken back from you. So we have to be very, very careful and very prudent with the money and the way it's spent and the way we turn in our documentation, make sure that every piece of documentation we submit to the Medicare program for review is as pristine as we can possibly get it. So oftentimes nurses, in particular, therapists not, I don't find that this to be true with therapists so much. Nurses don't like to talk about money, but we have to talk about money when we're talking about Medicare policy, because again, that's what we have to function on. And if you don't have a healthy organization, you have good revenue coming in, you're not going to have a healthy staff, and you're not, or I mean, as far as reimbursement is concerned, you're not going to have a healthy organization to be able to continue functioning. So every home care agency and every home care company nationwide has to work within a given budget. The organizations have to file a cost report at least once a year, and that cost report is required. And the more detail you can have in that cost report, the better off you're going to be as far as keeping the funds that you submitted to the Medicare program to try to accept, to have them accept. So again, Medicare is an insurance and it's not free. And I oftentimes hear people say, well, this is 100% covered, so it's all free. This is not free at all. Medicare is something that Medicare recipients have worked hard for their entire life. And it's at the time they turn 65, they're eligible to get this as an insurance program for themselves for health insurance. I've heard, I have read a number of things now that indicate that Medicare is planning on pushing Part A and Part B recipients into Medicare Advantage programs by the year 2030. We don't have anything solid in that regard yet, but as soon as we do, I'm sure all of you will be the first to know about that. But just keep that in mind, that the Medicare program that we talk about now, which is Part A, and part of it is also covered under Part B, but that is a program that may go away within the next 5 years. Insurance policies have coverage guidelines, and I explained to you about the, comparing Medicare with like home insurance policies, and so those policies must be met. Medicare policy provides us with a list of items, and I'm going to go over a few of those with you so that you have a better understanding of what we're talking about here. But there's also guidance for eligibility. Now, the conditions also have eligibility standards, and it's up to the survey department, up to the conditions of participation and those who comply with it, to assure that the eligibility criteria are well documented and the patient is screened, and you can assure that the patient is eligible for the coverage prior to doing an admission and having services provided in the home. So coverage for skilled nursing, of course, along with all the other disciplines, is outlined in the policy manual. And I'm going to cover a few of these and give you some examples as we go along. Providing care that's not covered is going to result in non-payment. And as I mentioned earlier, UPICs and ADRs and those types of things are reviews under the Medicare program. They trust us, and for the most part, for a very long time. And then all of a sudden we'll get a review, and those reviews can be anywhere from 1 to, I've seen 80 records looked at, and even more. Typically they'll they'll look at about 40 records. But if you didn't document covered services, and again, you may have completely compliant documentation related to conditions of participation, but it's not a covered service that you have documented according to Medicare policy, you're not going to get paid for it. So it's necessary for nurses and therapists to understand what's covered and what isn't. So complete and detailed documentation is going to be the key for agency payment by the Medicare program, but your QA staff and your staff in the field are going to have to understand what's required in order to make sure that that payment is going to be made. So there are things I call an obvious skill. So there are things that there's things that are easy to identify for, particularly for nurses, like wound care. You can, in fact, it's interesting. I had a family member who was at a Pittsburgh hospital just the last couple of weeks. And because I'm in home care, I said, make sure she gets home care when she's discharged. And when they recommended that to the nurse on the floor, she said, well, she's not going to be able to get home care because she does not have a wound. Well, that really has nothing to do with whether or not she qualifies for home care or not. So the misunderstanding about what is a skill and what isn't is pretty broad out there. And so we have to understand what that is. So wound care, teaching on new and changed medication, those types of things, we know that's a skill. But there's some other things that are covered that maybe you didn't even know about. So as long as a nurse can identify a skill as he or she knows it, recertifications are easy and pretty straightforward. And we can, we're finding with PDGM, oftentimes staff members are not getting past that first 30 days. They're not understanding what they need to do to keep that patient on for longer. Documentation for skill management and evaluation necessitates a more complex plan of care. We won't have any time to get into that today, but it's certainly something that you really need to understand and you need to use more often than it's being used now. I had one of the reviewers from a MAC tell me that they were surprised that agencies didn't use management and evaluation and maintenance for therapy more than they did for patients. And they actually encouraged the use of management and evaluation and maintenance therapy for patients. So let's talk about identifying a skill. So there are 15 items under the Medicare policy that's covered as a skill. So I'm going to go over each of these and give you a little background about each of them. Observation and assessment is a skill all by itself. So you may not do any of the other 14 items, but you are observing and assessing a patient. That particular skill is only good for 3 weeks. Now, read your policy so that you understand what I'm talking about here, but observation assessment is good for 3 weeks, or as long as the patient shows a risk for an exacerbation of some sort. And that documentation has to be very, very clear. Most of the time, probably 99% of the time, we're doing a combination of skills. We're not doing just observation assessment. We're also doing medication teaching. We're perhaps doing tube feedings, doing other things along with that. So observation assessment all by itself doesn't stand alone. But the G codes being used, and be very careful about these. So these billing codes that they're also called G codes, are, if you're documenting that the G code you're using is observation assessment for a full 9-week period, you're likely to get a review on that because observation assessment all by itself is only good for 3 weeks. Management and evaluation of a care plan is something else. As I mentioned, this is another one of my favorite things in the whole Medicare program, is where you are actually going into a home when a patient has stabilized as far as their clinical condition is concerned. They have an unskilled caregiver in the home, and the registered nurse has developed a care plan for that unskilled caregiver. And so the job of the registered nurse, and this by the way, can only be done by an RN. It cannot be done by an LPN or an LVN. The management and evaluation of a care plan can continue indefinitely. There's no time restrictions on this. I would be very careful, though, that if you are putting a patient on management and evaluation, that you are evaluating whether the patient continues to need that. And oftentimes I found agencies trying to use this as a way to put home health aides in the home when there wasn't really a skill needed. And so you really have to be careful about that. But it's a great tool to keep that patient on service for a period of time. And if they exacerbate during the time they're on this, then you can put them on the regular routine types of things. Teaching and training activities. Under teaching and training, you're going to find that 18 items are listed under teaching and training. Has to do with teaching of medications. New and changed medications are one of those things. And for some of you who don't know this, Medicare actually has a different definition for new and changed medications. New medications is anything that started, a new medication that started within the last 30 days, prior 30 days of admission, or during the period of time that they started medications during the time they're in service. Those would be considered new. A changed medication is a medication that's been changed in frequency, route of administration, or dose within the past 60 days. So those definitions you need to keep in mind. That should be part of your orientation process when you're training your staff. So many things under teaching and training, if you read through that, you're going to find that there are many, many things that we can market to physicians and let them know. Again, many physicians just think we do IVs and wound care, and that they don't understand that we can actually take on that role of teaching those new and changed medications that most of their patients, when they come in to do a visit with a physician, have happen. They typically change medications or treatments or something like that when a patient goes in to see them, as long as they're homebound. And the actual administration of medications is something that's paid for by the Medicare program. Tube feedings, aspirations, either trach or nasopharyngeal aspirations are covered. Catheters, of course, changing those catheters. Now there's some specifications in here. Most catheter changes should only be done every 30 days. Medicare in the policy actually identifies the types of catheters that should be used and the frequency of changes. I highly recommend that you have PRN orders if you have a catheter of any kind in a patient. You have PRN orders if something becomes dislodged, there's a problem, that you have the ability to change those catheters. Wound care, of course. Now, stage 1 and stage 2 wounds are not something that Medicare covers for a long period of time. They will cover wound care for stage 1 and stage 2 pressure ulcers if you are training a family member or caregiver to care for that stage 1 or stage 2 wound. The only thing that they will pay for a period of time, as far as dressings and that type of thing, are going to be stage 3 and stage 4 wounds as far as the documentation is concerned. Ostomy care is covered. Those are for new ostomies or any kind of revisions of ostomies. They're certainly not going to cover ostomy care for long periods of time just because the patient doesn't want to learn how to do it. But oftentimes there are problems with the ostomy even after the ostomy has been, a new surgical intervention has been done, and there needs to be some changes in appliances and that type of thing. And that care would be covered as long as you can document the necessity of that. Heat treatments can be done. Then in medical gases, of course, the only thing I can think of is oxygen with that. I've never had a really good explanation of what that would mean. Rehab nursing, prior to PPS, we had a difficult time in home care finding therapists. So oftentimes we put rehab programs together, and that's still possible. There are a number of things. If you look under the teaching and training aspect of coverage, you'll find there are a number of teaching and training items that we can do that would be considered rehab nursing, such as gait training and that type of thing. So rehab nursing is still well and alive in the Medicare program, and it's something that, particularly if you're in a rural environment, you may want to consider. I thought that with PDGM, we would see a lot more rehab nursing being done because therapy visits are more costly than nursing visits. And so those programs certainly are something some agencies may want to take a look at to decrease their cost in services as relates to PDGM. Venipuncture was something that, and many years ago, that this was allowed on a routine basis. And so basically, nurses would go into homes and act as med techs. They would just draw blood and do nothing else. You wouldn't have to take vital signs or anything. You just go in and draw blood, take it to the lab, get results. Many times the patients were on multiple venipunctures a week. Medicare put a stop to that in 1998. And they said, no longer can you do just venipuncture alone. You must have another skill. So one of these other 15 items would have to be covered, and or another skill discipline would have to be the primary in order for venipuncture to be covered. So as long as you're doing providing another skill, the venipuncture would be covered. It's not that it's not covered at all. It's just that it can't be the primary purpose for the patient staying on service. Skilled nursing visits, I think, is very interesting, and there are a number of agencies that consider this when they're, particularly with staffing challenges we have now. Often you have to have a contract with a school of nursing, of course, and their student nurses, typically when they have their home care rotations, they're probably in their 4th year of school. And there is no requirement that anyone goes with them to do these visits. So they would need to go through an orientation. Supervision is the responsibility of the School of Nursing. That's not a responsibility of the agency. But it's an interesting concept, and with the shortage of staff, it's something that maybe some of you might want to consider utilizing. Psych nursing is another program that's allowed under the Medicare program. And in most instances, there needs to be some qualified psych, there are requirements for that psych nurse, and so the resume and that type of thing. Sometimes that you even need to submit that resume to the MAC to get approval for that psych nurse to actually provide services. But for the most part, it's just having someone who has that training and understanding of psychiatric care of patients to be doing that. So these are the 15 items, and I would encourage you to look at the Medicare policy itself and get the detail behind this. They give you really good examples when you, and this is in Chapter 7, by the way, of the Medicare manuals, and they give you good examples, and you can use this as some marketing strategies for yourself when you're kind of stuck in getting the same types of referrals over and over and over again, and not seeing things that are different. So again, I would encourage you to take a look at that. As far as the conditions of participation, these are the conditions, and I'll just go through some of these rather quickly here. The first part of it in 484.40 has to do with OASIS, and certainly OASIS is a whole teaching plan in itself, so we're certainly not going to get into that, but just know that that is part of the conditions, and OASIS and all the requirements for OASIS are listed in this section. In 484.50, it talks about patient rights, and this is where that the detail about the patient rights and about the notice and what rights the patient has is listed. One of the things I find is happening more frequently now than I've ever seen before is the requirement under the transfer and discharge information for the patient, that there are certain requirements for the 48 hours, the 5 days of getting information to the transferring provider is being cited often by surveyors. So that's something to pay attention to. In patient rights, they talk about complaints and patient's accessibility, that we have to make sure that we assure that that patient has items accessible to them. They have reading information that they can actually read. If they're blind, that we have helped them with accessibility or hearing issues, speech issues that we pay for ourselves. But all of those things are listed in 44.50, and they are often cited as a condition level because they're sometimes there are items that the organization or the staff member does not comply with, and it impacts the entire condition. The comprehensive assessment of the patient talks about the entire assessment of the patient. So the OASIS assessment itself is not a comprehensive assessment. The OASIS assessment itself is data collection, and all of you know that there's a lot of data that we do collect, but the initial assessment and the content of the comprehensive assessment and the update of the comprehensive assessment all has to do with that integrated assessment that we must do along with our OASIS assessment. So all the guidelines for that are housed here in 4E to 4.55. In 5.8, they talk about discharge planning. And again, this is another place where I'm seeing a lot of citations where the discharge planning is not being done appropriately. With value-based purchasing, I've encouraged agencies to treat the discharge assessment and the planning of the discharge the very same way they do the start of care assessment. Oftentimes, clinicians will spend an awful lot of time on the start of care assessment, but the discharge assessment they rush through just to get it done as far as paperwork is concerned, and not paying attention to the content. And that's where, with value-based purchasing, that's where you're going to get paid. So making sure that you have a good discharge planning process in place and you have good outcomes at discharge. You are working as a team to make sure that the discharge is well planned and that your summary content is well documented and it gets to the appropriate provider in a timely fashion. So we want to make sure that we keep the plan of care simple. Eliminating your orders, I would rather see 4 orders and 4 goals on a plan of care than what I see many, many times is 25 orders and maybe 40 goals, and I'm not exaggerating. That happens often. You want to keep your plan of care simple. Keep it, look at your assessment, making sure that you are not getting too detailed, but detailed enough. One of the things I find, like for instance, if patient is at a fall risk, oftentimes I see the clinician will document, fall safety. Well, what does that mean? Those interventions need to be outlined more specifically. So, but getting back to the limiting of orders, you want to make sure that you have orders that physicians are actually going to read and determine that they make sense and they're going to sign off of them. Make sure that the clinicians are limiting their goals. Again, 40 goals on a patient is absolutely impossible to accomplish in a 60-day period. So make sure that those goals are appropriate for that patient and that you can accomplish them within 60 days. Changes on the plan of care, make sure that you are changing that plan of care when it's necessary. If it's necessary to change it significantly, you're probably going to want to do a SCIC assessment, a significant change in condition assessment, which is nothing more than a recertification assessment. You would have updated orders, and that assessment would not be transmitted. It's an OASIS assessment, would not be transmitted, but it would be housed in the clinical record. Maintaining contact with a physician, this is one place where, again, I see oftentimes citations from the surveyors that there's not enough contact. And this is also coming up with UPICs and ADRs. There's not enough contact with physician. So frequent contact with that physician and notifying with abnormalities and your findings is really important. So your QA staff really need to be paying attention to visit notes, making sure that every single order, as a matter of fact, I just got a plan of correction over the weekend that I needed to do for someone, and one of the corrective actions was they were not following the orders on the plan of care. Be assured that every one of the accrediting bodies and the state surveyors are looking at every single order that's documented on the plan of care, and they're comparing it to the note and making sure that each one of those orders are followed. Compliance, again, is related to both survey and Medicare policy. They're looked at differently. Compliance, as far as the conditions are concerned, and Medicare conditions of participation are going to be, you're probably going to be hit with citations. There are monetary challenges there too. We won't get into that today, but primarily they are, you're found out of compliance and you have to write a productive plan of correction. For Medicare policy, of course, you're actually are vulnerable with having money taken away from you. So we want to make sure that our documentation supports both quality and also with payment. Care plan coordination, condition of participation, care planning coordination services, and quality of care are all under 484.60. And this includes, and this used to be separated, and I kind of liked it separated better than I do with it all being lumped in together here. But with this condition, they're looking at the plan of care, making sure you're following orders again, a review and revision of the plan of care if it's necessary, coordination of care, and any kind of written information to the patient is all included here. So if they cite you on one of these items, then it can affect this entire condition. These are the references that I've used to pull this PowerPoint together for you, and I would encourage you to take a look at these. The immediate jeopardy is something I mentioned to you, that there are monetary obligations with conditions of participation. If you are found to have a patient who has potential or real safety risks, you can be cited with something called immediate jeopardy and be fined thousands of dollars a day until that item is corrected. And that actually forces many home care companies into bankruptcy if that ever is found. Some of you who worked in nursing homes know well what immediate jeopardy is. You can find that in Appendix Q. I have not listed Appendix Q here, but that's where you'll find that. Appendix Z houses the emergency plan, and this is something that I did not cover in this session, but you all know that you have to have an emergency plan, and that is part of the conditions of participation. So if you have any questions, I'm happy to answer those for you. If you have questions at after we're done with this webinar, you can certainly email me or email Mike, and we're happy to answer any questions you have on either the conditions or Medicare policy. And I want to thank each one of you for attending today. And again, Mike, if you have any questions, I'm happy to answer them. If not, we can end the session.
Yep, I did not a nice job, first of all. There were not any questions in the question panel, but certainly the folks are, as you mentioned, welcome to reach out to you at amaxim@axxess.com. And if you have questions about the CEUs, let me know. And again, my name is Mike Carr, so it's mcarr with 2 R's at axxess.com. I did drop into the chat panel the link to Chapter 7 as well as Appendix B as well if you need those, and we'll provide you a PDF of the slides in an email communication in the next couple of days. So great job, Arlene, as always.
Thank you. Thank you, Mike. Thank you, everyone, for attending. Look forward to next time.
Take care. Have a nice day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.